Imagine, just for a second, trying to quit a substance that has completely taken over your life. You finally make the brave decision to seek help.
Right, which is incredibly hard to do.
Exactly. So you walk into a clinic and you're handed the standard life-saving medicine that's designed specifically to ease your pain and help you recover.
Yeah.
You take it, and instead of relief, your body is instantly thrown into this catastrophic, agonizing withdrawal. I mean, it is the absolute worst you have ever felt. And this is the terrifying reality of opioid addiction treatment right now in the fentanyl era.
It really is.
Yeah.
The tools that have reliably saved millions of lives over, the last few decades, they're suddenly triggering the exact crisis they were designed to prevent. It's a devastating paradox for patients.
And that is our mission for today's deep dive. We're exploring this unexpected, rapidly emerging tool that scientists are testing to bridge this dangerous gap. And that tool is ketamine.
Yeah, ketamine, which is wild to think about.
It is. We're looking at a whole stack of recent clinical case reports, molecular biology reviews, and the latest clinical considerations from ASAM, the American Society of Addiction Medicine. We want to understand exactly how ketamine interacts with the addicted brain.
To do that properly, we really have to look at the landscape from a few different altitudes, I think. We need to examine why the standard treatments are just failing so spectacularly against fentanyl right now.
Right.
And then we'll zoom way in, to the microscopic world of cellular rebalancing to see what ketamine is actually doing to our receptors. And crucially, we need to bust this pervasive myth of the ketamine reset button that's been making headlines.
Oh, yeah, we definitely need to talk about that reset myth. And finally, we will look at the gritty, real-world clinical trials testing this theory on patients right now. Okay, let's unpack this.
Let's do it.
We have to start with the specific problem fentanyl creates before we can even begin to understand why ketamine is being proposed as a solution. Historically, opioid agonist therapy, which we'll just call OAT, using medications like methadone or buprenorphine, has been the absolute gold standard, right?
Oh, absolutely. It reduces overdose, keeps people in treatment, lowers mortality. I mean, it works.
Right, it works. But the chemical structure of fentanyl has completely changed the rules of engagement here.
It really has.
No.
The core issue is that fentanyl is highly lipophilic. That simply means it loves fat.
It loves fat.
Yeah. When someone uses fentanyl repeatedly, the drug doesn't just process through the bloodstream and disappear. It actually hides out in the body's fatty tissue stores, and then it leaches out slowly over a really long time.
Like long after the immediate high is worn off.
Exactly, days later even. So a patient goes into a clinic to get clean, and the doctor prescribes buprenorphine. Now, buprenorphine is what's called a partial agonist. It binds to the brain's mu-opioid receptors to curb cravings, but without delivering that dangerous high.
But there's a complication, right? Because of how buprenorphine behaves.
Yeah, a massive one. Buprenorphine has an incredibly strong affinity for those receptors. It binds to them tighter than almost anything else.
Okay.
So when it's introduced to a patient who has been using fentanyl, it acts like a battering ram. It aggressively knocks any residual fentanyl right off those mu-opioid receptors to claim the space for itself.
And because fentanyl hides out in the fat tissues, constantly slow releasing, there's almost always residual fentanyl still hanging around in a patient's system days after their last use.
Yes.
Think about it this way. Imagine fentanyl is a stubborn, destructive squatter hiding inside the walls of a house, which represents your fat tissues.
That's a great way to picture it.
Right. So when buprenorphine shows up to change the locks on the front door, that squatter doesn't just pack up and leave quietly. It fights back violently, causing massive structural damage on the way out. Biologically, this is called buprenorphine-precipitated opioid withdrawal, or BPOW.
And that structural damage in your analogy, it translates to an agonizing physical and mental experience for the patient. The withdrawal is sudden, explosive, and infinitely more severe than natural withdrawal.
Oh, wow.
Yeah, in the past, doctors would use standard helper medications to ease people through the transition. Things like clonidine for blood pressure, hydroxyzine for anxiety, or loperamide for stomach issues.
And those used to work, right?
They worked perfectly fine for heroin withdrawal. But they simply aren't strong enough for the extreme, explosive withdrawal triggered by high-potency synthetic opioids like fentanyl.
It sounds like an absolute nightmare scenario for the patient. And then you have methadone, which is the other major OAT option.
Right. Methadone is a bit different. It doesn't act as a battering ram because it's a full agonist, so it doesn't cause precipitated withdrawal in that same violent way.
But the sources show that initiating methadone has massive early dropout rates.
Yeah.
And that dropout rate is largely driven by comorbid severe depression, right?
Exactly. Patients are just so profoundly miserable and depressed early in the methadone induction process that they just leave the program.
So if we look at the clinical reality of both these options, we're looking at a massive psychological barrier to recovery. This isn't just a physical hurdle of getting through a few days of sickness.
Not at all. When a patient experiences precipitated withdrawal from buprenorphine or that crushing depression during methadone induction, they become terrified of the cure.
Yeah, the medication that's supposed to save them becomes this source of profound trauma.
And so they drop out of treatment, go back to the street to find relief, and often they don't come back.
So if the current medications are essentially triggering this catastrophic response because of fentanyl's staying power, how do we fix it? I mean, to understand how an anesthetic like ketamine might help patients get through this agonizing process, we have to look under the hood.
Yeah.
We need to look at what chronic fentanyl exposure actually does to the brain's receptors over time.
Right. Let's start with how mu-opioid receptors usually function in a healthy brain. We all have these receptors, and they're built to interact with endogenous opioids.
Which are the natural painkillers and mood regulators our own bodies produce, like endorphins.
Exactly. When an opioid, natural or synthetic, attaches to these receptors, they send signals for pain relief, euphoria, relaxation. But the brain is a highly regulated environment. It demands homeostasis or balance.
He doesn't want that signal to stay turned on forever at maximum volume.
No, it really doesn't. The brain wants to protect itself from being overstimulated, so it deploys a cellular regulator, a protein called beta-arrestin. The sources describe beta-arrestin like a biological brake pedal.
So when a patient uses high doses of opioids chronically, those receptors are just constantly screaming.
Right, and beta-arrestin rushes in and attaches to the overstimulated receptor to prevent further signaling. It effectively tells the receptor to shut down.
Okay, that makes sense.
And it achieves this through a process called receptor internalization. The cell physically pulls the mu-opioid receptors from the surface to the inside of the cell. They are swallowed up so they can't be activated by any opioids floating around outside.
Let's put this into a real-world scenario. Think of it like a popular retail store facing a massive, chaotic mob of buyers.
Oh, I like this.
Right. To prevent the store from being completely torn apart, the manager takes their high-demand products off the showroom floor and hides them in the back warehouse. The products still exist, but the customers, or in this case the opioid molecules, they just can't reach them anymore.
That is exactly it. And that cellular action directly explains the tragic clinical reality of addiction.
Because if you have fewer opioid receptors available on the surface, the brain has less sensitivity to opioids.
Precisely. That means a person needs larger and larger doses of the drug just to get the same effect. And eventually they need massive doses just to stave off sickness and feel baseline normal. Yeah, this process, driven by beta-arrestin and receptor internalization, that is the exact biological mechanism of opioid tolerance.
So the receptors are hiding inside the cell. The patient has massive tolerance, taking huge amounts of fentanyl just to function, and if they try to switch to buprenorphine, they get thrown into violent withdrawal. So how does ketamine fit into this microscopic puzzle?
That is the big question.
Like, does it just coax those receptors out of the back warehouse and put them back on the shelf?
It's a bit more complex than just bringing them out of hiding. It targets the specific neural pathways that drive that entire hypersensitivity loop. Ketamine's primary mechanism of action is that it's an NMDA receptor antagonist. It blocks NMDA receptors.
Let's define that, because NMDA receptors are crucial here, and these aren't opioid receptors, right?
No, they're entirely different.
Right, NMDA receptors act essentially like an amplifier for the nervous system's pain and memory pathways.
Yes, exactly. When they are overactive, which happens during chronic opioid use, and especially during withdrawal, they flood the brain cells with calcium.
And what does that do?
This calcium flood wires the nervous system to be hyperreactive. It drives opioid tolerance, and it causes something called opioid-induced hyperalgesia, which is a state where the nervous system becomes so sensitized that ordinary touch can feel like severe pain.
Oh, wow. So by blocking the NMDA receptor, ketamine essentially unplugs the amplifier. It stops that flood of calcium and halts the hypersensitivity.
Exactly. It quiets the alarm bells in the nervous system. But our sources also mention some really specific cell-based laboratory studies, like the 2022 assay by Mizubuchi and colleagues.
Right, they looked beyond just the NMDA blockade.
They did. They found that ketamine at normal clinical concentrations actually improves mu-opioid receptor desensitization and enhances that beta-arrestin recruitment.
They found it does this via what are called GRK-mediated pathways, right?
Yes. GRK stands for G protein-coupled receptor kinases.
Okay, that's a mouthful.
It is, yeah. But you can think of GRKs as a cellular tagging system. They tag the overworked opioid receptor so the beta-arrestin knows exactly where to go to regulate them properly.
Oh, so in a brain battered by fentanyl, this entire tagging and regulating system is chaotic and impaired.
Exactly. And ketamine seems to help normalize that GRK pathway, helping the opioid receptors cycle more functionally rather than just shutting down entirely.
That's fascinating.
But there is a massive, crucial nuance in that Mizubuchi study. Ketamine only works this specific way with fentanyl. It did not have this regulating effect on cells exposed to morphine.
Wait, let me stop you there, because the media has run wild with headlines framing ketamine as this magical cure-all for addiction.
Oh, I know. It's everywhere.
If I'm reading these mechanisms right, this isn't a factory reset button for the brain. Like, if a patient is given ketamine, we can't just treat them like they have never taken an opioid before, can we?
No, absolutely not. The scientific data absolutely refutes the idea of a reset. The concept that ketamine fully resets the central nervous system back to a pristine, opioid-naive baseline is a complete myth.
Right, the consensus guidelines we reviewed from ASRA, AAPM, and ASA specifically note that studies looking for a complete reversal of central sensitization have mostly yielded negative findings. It doesn't erase the damage completely.
Right. So the sources explicitly call it a partial rebalancing.
A partial rebalancing, okay.
Ketamine helps fix dysregulated nodes in the brain's network. It calms the NMDA amplifier. It improves the impaired receptor cycling we talked about. And it boosts the body's natural endogenous opioid signaling.
But it does not flip a switch back to zero.
No. A patient receiving ketamine during their OAT initiation still has massive opioid tolerance. Their doses of methadone or buprenorphine still require incredibly careful medical adjustments that account for that existing tolerance.
And the opioid-sparing effect of ketamine, meaning it reduces the amount of opioids a patient needs to feel relief, that is a real phenomenon, but it's partial.
Right.
It reduces the requirement. It doesn't eliminate the need entirely.
Exactly.
Furthermore, these neurobiological benefits are temporary, aren't they?
They are completely time-limited. If the ketamine treatment stops and the underlying opioid exposure pattern doesn't change, the maladaptive neuroplasticity will just return. The brain will go right back to hiding those receptors and turning up the NMDA amplifiers.
So ketamine creates a favorable window, a better, calmer neurobiological environment to successfully start OAT, but it is a bridge, not a permanent destination.
That's the perfect way to phrase it. It's a bridge.
Well, theory and cellular tagging systems are fascinating, but we really need to know what happens when you actually administer ketamine to a human being who is actively going through severe fentanyl withdrawal.
Yeah, how does this partial rebalancing look in practice?
Yeah, exactly. We have to state clearly that the clinical evidence right now is highly investigational. We are not looking at definitive, large-scale data.
No, we are looking at case reports, case series, and small feasibility trials. There are currently no large randomized controlled trials RCTs completed for this specific use case of initiating OAT in fentanyl users.
But the investigational data we do have paints a really vivid picture of both the promise and the danger. Let's start with the 2025 trial by Mansa and colleagues.
Okay, yeah.
This was an open-label feasibility trial with a tiny sample size of just 3 patients. But look at their specific protocol. These patients received 0.5 milligrams per kilogram of IV ketamine over 40 minutes. And they did this 3 times a week for 2 weeks, right as they were beginning methadone treatment.
And the results for those 3 patients were remarkably promising for that specific context. All 3 patients successfully stayed in the methadone treatment at the 3-month mark.
Which is huge.
It is. And crucially, their comorbid severe depression, which we noted earlier, is the primary reason people drop out of methadone induction. That dropped to just mild or moderate levels.
That points to a really fascinating dual benefit. The ketamine isn't just smoothing out the physiological opioid receptors, it's actively acting as a rapid psychiatric intervention to treat the severe depression that makes people abandon methadone programs in those vulnerable early weeks.
Yes. But if you contrast the controlled environment of the Mansa trial with the 2025 Guji case report, you get a much messier, chaotic reality.
Yeah, Let's talk about the Gucci report.
It is a textbook example of ketamine being used as a desperate emergency rescue rather than a scheduled psychiatric tool.
Right.
This involved a single patient who was experiencing intractable, agonizing, buprenorphine-precipitated opioid withdrawal in the emergency room. The standard comfort meds had completely failed. The patient was in absolute agony.
So the medical team gave the patient a relatively large IV ketamine bolus of 27 milligrams.
Yeah. And initially they saw an improvement in the physical withdrawal symptoms. The partial rebalancing seemed to be working.
But then what happened?
Then the patient developed what is called emergence delirium. They became intensely agitated, disoriented, and confused to the point where the medical team had to intervene and administer a dose of haloperidol, a strong antipsychotic medication, just to calm the patient down and ensure their safety.
Wow. Ultimately, the patient did stabilize on their buprenorphine, but the process was harrowing.
It perfectly encapsulates the dual utility and the dual risk of ketamine. In the Manza trial, it's a scheduled, controlled psychiatric bridge, keeping people engaged in methadone.
And in the Djibouti case, it's an acute physiological sledgehammer used to rescue a failed buprenorphine induction, but it comes with severe behavioral side effects.
Exactly.
So what does this all mean for you, the listener? If you or a loved one are navigating this horrific landscape of fentanyl addiction today, you can't just walk into your local outpatient clinic and ask for a ketamine drip, right?
No, that is simply not an option right now. And the Djibouti case report raises the critical issue of safety and how the medical establishment is actually deploying this tool. Ketamine comes with heavy pharmacological baggage.
The dissociative symptoms, the hallucinations, the emergence delirium we just talked about.
Yes, all of that.
And there are also strong sympathomimetic effects, meaning ketamine naturally spikes your heart rate and your blood pressure.
Which is already dangerously high during opioid withdrawal. Not to mention, ketamine itself is a controlled substance with its own potential for misuse.
Because of all these compounding risks, ketamine for opioid withdrawal is strictly limited to monitored inpatient settings, isn't it?
It is. We are talking about the intensive care unit, the emergency department, or a general medical floor where nurses and physicians can provide close, continuous cardiovascular and psychiatric observation.
And what do the official guidelines say about all this?
Well, the 2023 ASAM Clinical Considerations document is incredibly clear that ketamine is absolutely not a first-line therapy.
Right.
It is listed strictly as an escalation option for intractable, treatment-resistant withdrawal. It's grouped alongside heavy hitters like intravenous benzodiazepines and dexmedetomidine, which are serious sedatives.
There isn't even a standardized dosing protocol across hospitals yet.
No, not at all. We are firmly in the feasibility stage of medical research. Doctors are proving that it biologically can be done and it can work, but we need massive, standardized, randomized controlled trials before this ever becomes a routine standard of care that you'd see in a standard rehab clinic.
So let's distill all of this down. Fentanyl has fundamentally broken the standard models of OAT initiation. The old ways of starting buprenorphine just aren't working against these highly lipophilic synthetic opioids, leading to agonizing precipitated withdrawal.
And ketamine offers a biologically plausible way forward by turning off the NMDA amplifiers in the brain and helping regulate the beta-arrestin tagging system.
It provides a partial rebalancing, creating a temporary, calmer window of opportunity for patients to get stabilized on life-saving medications. But it is an investigational, powerful escalation tool with serious side effects. It is not a magic cure.
Right, it requires deep medical supervision and a highly controlled environment. But for patients who have failed every other option, it offers a scientifically grounded hope where traditional pathways are currently falling short.
And I want to leave you with a final thought to mull over, building on a really specific detail from our sources today. Remember the Mizubuchi study we discussed?
Oh yeah, the one with the cellular tagging?
Right. It noted that ketamine's beta-arrestin regulating mechanism worked specifically for fentanyl, but it completely failed to work for morphine.
Yeah, that was a huge detail.
That implies that opioid tolerance isn't just one universal monolithic mechanism that works the same way for every drug. The molecular mechanism of addiction changes depending on the specific synthetic chemical used.
Which changes how we have to look at treatment entirely.
Exactly. Could the future of addiction medicine require us to perfectly match an antagonist or a helper medication to the exact molecular signature of the specific synthetic opioid a person took? Will the era of one-size-fits-all rehab soon be replaced by precision, molecularly tailored recovery?
It is a fascinating question to consider.
It really is. We started today talking about that catastrophic, agonizing withdrawal, that moment where the cure feels worse than the disease. As science uncovers these hyper-specific molecular keys, maybe we are finally getting closer to ensuring that when someone bravely reaches out for help, the medicine actually saves them.